Very good evening, one and all. So, welcome to TIPS Excel Masterclass series on organic psychiatry topic. So, I'm Dr. Vishnu Priya. I'll be discussing two important organic psychiatry topics. One is like tuberous sclerosis and its neuropsychiatric manifestation, followed by neurofibromatosis. Both these topics are very important for university exams as they can be asked as long note and short note. Sometimes the neurocutaneous markers can be kept as spotters also. So let us move on to the topic. So in today's presentation, we'll be seeing what are phacomatosis, what are the clinical features. First, I'm going to start with tuberous sclerosis, pathophysiology of it, the neurological manifestation, the psychiatric manifestation, and what is TAND, that is tuberous sclerosis associated neuropsychiatric disorder, and the findings from the famous TOSCA study, that is the largest natural core study of tuberous sclerosis conducted so far. What are the assessment tools that needs to be used whenever we are suspecting a neuropsychiatric manifestation in tuberous sclerosis? And what are the pharmacological and non-pharmacological options we have to treat the same? So now moving on to the topic, I would like to present my topic. Initially, I would like to explain a concept called phacomatosis. So what is basically phacomatosis? So phacomatosis are conditions that involve both the skin as well as the central nervous system. So basically, they arise because of some defects of the developing primitive embryonic ectodermal tissue. As we all know that the embryonic ectodermal tissue has connections with the central nervous system because the embryologically the tissue starts spreading in that manner. So as the name itself implies, since it affects the embryonic ectodermal tissue, these two conditions have manifestations in almost all systems as it evades and invades the all systems possible, starting from CNS to GI tract to liver to heart. So there will be a multiple varied clinical presentation and systemic manifestations in almost all systems. So this phacomatosis can be broadly classified as rasopathies and tauropathies. I'll be explaining it in subsequent slides. So first we are going to deal with tuberous sclerosis. So it is basically tauropathy. We can remember like that T for T. So tauropathy is tuberous sclerosis. Actually, tuberous sclerosis encodes a protein called Reb protein. So this Reb protein is essential for our cellular growth and proliferation. So when there is loss of function mutation or when the function gets lost in tuberous sclerosis, then there will be excessive growth or overgrowth leading to the abnormal cell tissue and cellular proliferation. So the tuberous sclerosis, as it is commonly referred as TSC complex, that is tuberous sclerosis complex, is found in 1 to 6,000 individuals, and there are two types. One is tuberous sclerosis 1 that lies on chromosome number 9q34 and it harbors a protein called amartin, and the tuberous sclerosis 2 that maps to chromosome 16p13.3 and it maps a protein called tuberin. So coming on to the diagnostic criteria, so the international consensus of tuberous sclerosis in 2012, they gave this genetic diagnostic criteria. So whenever we subject the individual to genetic testing, that is whole exome sequencing, so we should be able to identify a TSC1 or TSC2 pathogenic mutation in DNA from normal tissue. So when we are able to isolate that alone, that is itself sufficient to make a diagnosis. So what are these mutations basically? They are either out of frame mutation, indel mutation that can be deletions, duplications or additions, or nonsense mutation or large genomic deletion or missense mutation. So either one can be there, and ultimately all these mutations result in the loss of the protein function that is meant to be. That is the whichever protein the tuberous sclerosis codes, that protein function gets lost and ultimately it leads to excessive cellular proliferation. But actually, genetic testing in tuberous sclerosis is very controversial. So even when we work with the pediatric neurologist and with the pediatricians, generally they don't recommend genetic testing, though it is given as a criteria, because the whole exome sequencing has got a lot of financial implications on the side of the patient. On the other hand, we can easily diagnose tuberous sclerosis with the help of neurocutaneous marker itself if when we do a proper general physical examination. So, though it is being given as a proper diagnostic criteria, it is usually kept as a last resort, whereas clinical features are given an upper hand on diagnosis. So now moving on to the major and minor criteria. So if to diagnose tuberous sclerosis, at least two major criteria should be there, or one major with two minor criteria should be there. So regarding the major criteria, as we all know, there can be hypomelanotic papules more than 3 in number, at least of 5 millimeter in diameter, angiofibromas, ungual, that is nail fibroma, shagreen patch, cortical dysplasias, subependymal nodules, anything can be there, at least two should be there. In minor features, they have given something called the confetti skin lesions, dental enamel pits, intraoral oral fibromas, multiple renal cysts. So it is either two major or one major and two minor. Now coming on to the systemic manifestations of tuberous sclerosis, as we all can see, so it erodes almost all system possible. So here we can see that the renal manifestations might include cyst, angiomyolipidomas, and in skin it might result in fibromas or hypomelanotic patches. In heart, there can be rhabdomyolipidomas. In central nervous system, 90% of these children present with infantile spasm and pediatric epilepsy syndromes. And finally, our own area, that is TAND, tuberous sclerosis associated neuropsychiatric disorder. So in this presentation, I am going to focus only on the neurological and psychiatric aspect, and the focus is not going to be on the systemic manifestation as it is not in our domain. So these are few examples of the systemic manifestations. In the first figure, we can see a hypomelanotic patch. Here, it's a white patch, which is generally seen through a proper systemic examination. Then these are the hyper pigmented, that is shagreen patches. And here, as we can see, there are few areas of hyperintensity that are nothing but the cortical tubers in the MRI brain. So now coming to the pathology. What is mTOR signaling pathway? The expansion is mechanistic or mammalian target of rapamycin receptor. So basically they have found that these receptors are blocked by a drug called rapamycin, and hence they have given the name as mechanistic target of rapamycin. And rapamycin, we have to remember that it is a drug that is being given as a precision medicine. Latest research have been going on in this particular molecule. So now coming to the mechanism. So what basically happens in mTOR signaling pathway? So when the tuberous sclerosis gene 1 and 2 is functioning adequately, or if when the function is good, then it controls a protein called Rep protein. So the Rep protein is responsible for the controlled cell growth. So the cell proliferation and apoptosis are kept in check. Whereas whenever there is an abnormal mutation or loss of function mutation of this tuberous sclerosis, then what happens is this Reb protein or the entire pathway get hyperactivated. So the mTOR signaling pathway becomes hyperexcitable, or it becomes overactivated, and that results in excessive cellular proliferation and uncontrolled apoptosis or the cell death become problematic. So that is why we can understand that everywhere the cells get proliferated, and that results in fibromas, that results in myolipidomas, that results in this ungual fibromas, angiofibromas. So in short, we have to understand that the cellular proliferation happens in place where it is not meant to happen. So that is the very base of this mTOR signaling pathway. So why should we know this? Because only when we understand this mTOR signaling pathway, we'll be able to understand the precision medicine these days. So which has been completely targeted towards controlling the hyperexcitability of this particular mTOR signaling pathway. So now coming to the neurological manifestation, as I already said, seizures constitutes nearly 90% of the total neurological complication. Mostly the children present with infantile spasm. So they present very early during the initial 1 year of period of life, around 3 months, 4 months itself, and all type of seizure except focal. Focal is very uncommon. So can focal generalized can also present, but generally overall focal seizures incidence is very less. So early onset poorly controlled seizures that leads to a future development of autism spectrum disorder, severe cognitive decline, anxiety and depressive disorders. So there is a general rule of thumb in pediatric neurology that whenever any pediatric neurology condition is associated with seizure, then there is very high chances of development of any neurodevelopmental disorders. It can be ASD, it can be intellectual deficit. So the poorly controlled seizure is directly proportional to the behavior and psychiatric manifestation also. So either the seizure per se, or the underlying condition, or the adversities of the anti-seizure medication, all these collaboratively that might contribute to the behavioral disturbances in the child. So now coming to the autism spectrum disorder, nearly 40 to 70 percentage of the tuberous sclerosis children have ASD, but it contributes to less than 4 percentage of the total ASD cases. So overall contribution is less, but when you consider, for example, if 100 children with ASD, nearly 70 percentage of them show ASD features. And the risk factors, as I already mentioned, especially uncontrolled seizures, infantile spasm, and intellectual deficit. So here I would like to highlight few points on the genetic testing. So tuberous sclerosis and neurofibromatosis, they contribute to the genetic or syndromic ASD. So generally, the American Society of Medical Genetics or the international consensus, they recommend that whenever you have any child with ASD, then all of them has to be, and when you suspect a syndromic ASD, then you have to subject them to karyotyping, DNA for Fragile X syndrome, and FISH test. And if it is a female, then we have to check for MECP2 mutation that may contribute to the Rett syndrome. But actually, again, the use of karyotyping or DNA is a very controversial topic, and nowadays it is being slowly replaced with whole exome sequencing. So mostly when we suspect a genetic etiology of ASD, these days the pediatric neurologist and others suggest generally whole exome sequencing rather than going for a karyotyping or FISH. And now coming to the cognitive impairment. So we have to, the longitudinal studies have proved that though the IQ is very less when compared with that of the general population, actually cognitive impairment has got a bimodal distribution. So in this graph, you can see two peaks. So one is a very low IQ range of 40 to 60. So the majority of the children or adults with tuberous sclerosis might fall into this particular graph, or they might have a very no, subnormal intelligence of around 80 to 100. So overall, it has been said that the overall IQ of this population is very less when compared with that of the normal population. So cognitive impairment has got a bimodal distribution. Now coming to the executive function deficits. So majority of these children tend to have executive impairments. They have problems in planning, programming, execution, motor skill, and organization. So cognitive inflexibility happens in these children. So they have difficulties in performing complicated spatial working memory tasks, and attention deficits are very prominent, especially while doing multitasking or dual tasking, and they have impairment in memory, especially recall memory. So what happens when there is executive function defects? This will leads to intellectual issues, and ultimately that leads to academic and poor scholastic performance. So this imaging finding, so flare imaging and this magnetic transfer imaging, where we can see very minute details of the soft tissue. So this can add sensitivity in detecting the cortical tubers, because when we are able to detect at the cortical tuber itself, then the diagnostic criteria is almost full. So on magnetic resonance spectroscopy, I have also found that there is a decreased NAA intake, that is N-acetyl aspartate intake, and diffusion tensor imaging has also recorded the white matter tract damage. So we have to understand that these are certain conditions which involve both the gray matter as well as the white matter together. Now coming to the focus of interest of today's presentation, that is TAND, tuberous sclerosis associated neuropsychiatric disorder. So basically it is divided into four broad categories. So under behavioral domains, we have to look for sleep, any aggression, anxiety disorders. These three are commonly found in children and adolescents, whereas self-harm, internalizing disorders, anxiety, mood are commonly found in adults. Now coming to the psychiatry aspects, neurodevelopmental disorders are the commonest comorbidities. Autism nearly present in 50%, ADHD again 30 to 40 percentage, and intellectual deficits are around 60 percentage. And when coming to learning issue, so specific learning disabilities, academic difficulties are very prominent in the TAN, and psychosocial issues. So we have to understand that these conditions pose grave financial burden on the family, because when you have an intractable epilepsy, when you have infantile spasm, then the quality of life starts to get impaired for the entire family. It's like a lot of sleepless nights, sudden seizure status can happen. And the medications, for example, if the child is having DRE, that is drug resistant epilepsy, in the case of tuberous sclerosis, then we have to go for higher medications like vigabatrin. These have a lot of cost implications, so ultimately leading to low self-esteem for the family and lot of familial conflicts. So this is the famous stand checklist. So as a psychiatrist, we are supposed to learn this checklist. So whenever we have a child with tuberous sclerosis, we have to know how to administer this checklist. So nearly 12 questions are there under this checklist. So we will start from the basic developmental milestones, and we will probe more towards the current level of functioning, the behavioral concern, psychiatric disorders, the current state of intellectual functioning, academic skills, neuropsychological skills, through standardized neuropsychological batteries, what is the psychosocial functioning, and finally we will prioritize the list as to which has needs to be addressed immediately. So this is the TAND checklist. These are few questions from that. I have given a few snippets from the questions. So first, in the first question, we can see that we probe on the developmental milestones, that when did the child smile first, and when did it sit without support, and toilet training, whether it has been achieved or not. And in problem behaviors, we will probe on the autism spectrum disorders, ADHD, depressive disorders, OCD. And well, talking about the behaviors, we will focus on the anxiety, depression, temper tantrums, aggression. So almost all domains of psychiatric disorders are covered under this stand checklist. So when we have to divide it, the behavioral issues according to the TAND checklist, we have six major issues. So first is behavior. So behavior, we will focus whether the child is having aggression, temper tantrums, hyperactivity, impulsivity, social communication related disorders. So we have to understand that when we focus on behavior, we are focusing more on the problems which happens in autism spectrum and ADHD. So on psychiatry level, we will try to make whether the child fulfills a co-occurring diagnosis of ASD, ADHD, whether internalizing disorders are present. Under intellectual level, what is the current level of intellectual functioning? We can ask simple questions to the mother, that though the child is now 8 years of age, so according to you, at what level of age is the intellectual functioning of the child? So the mother will be very well able to say that the child behaves like a 4-year-old kid, the child behaves like a 3-year-old kid. Then we can subject the child to further standardized IQ test, and we can get a proper IQ of the child. Then at the academic level, whether the child is going to school, whether the child is having problem with reading, writing, mathematics. And under neuropsychological level, we have to target on the symptoms, like whether the child has difficulty in sustaining attention, whether it is able to do a proper dual tasking, or spatial working memory is intact or not, and what is the psychosocial level of the child as well as the family, whether the child is having self-esteem concern, low mood, or any parental conflict because of the child. All these things needs to be considered. So generally the recommendation is that the stand checklist, even in the checklist, it will be clearly given that it is stand lifetime checklist that needs to be administered every year. So comprehensive neuropsychiatric screening for children is recommended for 0 to 3 years, once 3 to 6 years, once 6 to 9 years, once 12 to 16, and 18 to 25 years. So now coming to the stepwise management. So we have administered the TAN, we have got few problem domains, then what is next? So what we have as a psychiatrist, we should perform regular evaluation of the cognitive development and behavior, and customized analysis, because every child with tuberous sclerosis has different needs. Few children only have ASD features, subtle ASD features without much issue. Few children don't have neurodevelopmental issues but have problems in learning, or few children have lot of psychiatric manifestations like psychosis that can be because of tuberous sclerosis per se, or because of epilepsy complicating the picture. So we have to have customized individualized plan for each of the child, and there are three aspects in the management. One is the neurological aspects that the neurologists do by controlling the seizure. As we all know that controlling the seizure is the first step to bring down the behavior. Second, as a psychiatrist, we have to administer the TAND, and we have to prioritize the needs of the child. And third, we have to align with the allied healthcare workers like the therapists, the special educators in devising an individualized education plan. So overall, we have to understand that it is actually a teamwork. It's not a work which can be done by one of the individual. It is ultimately the teamwork. So we have to evaluate the alterations in the cognitive function, and we have to investigate for the changes in behavior, and finally we have to subject the child for neuropsychological and behavioral testing. So this is the famous TOSCA study, that is tuberous sclerosis registry to increase disease awareness. It is the longest natural history study, and it is done in multi centers, and nearly 2216 participants were involved. done across 170 sites over 31 countries. So, what are the findings of this TOSCA study? So, they have categorized the TAND under five different headings on the study. So, they have reported that on the behavioral level, when it in children, as I already mentioned, hyperactivity, sleep disturbances, impulsivity are very, very, very common. Whereas when the child evolves into adolescence or into the adulthood, these features reduce a lot. And we already know that the natural course of even ADHD in a typical ADHD child also, initially it will be more hyperactivity. Then as the brain matures, then the hyperactivity comes down and it is only inattention. So the same concept applies here also. So the initial phase of the neurodevelopment, it is mostly hyperactivity, restlessness. When the child goes into adulthood, then it is more of internalizing disorders, mood disorders, psychosis, self-injurious behaviors, and all those things. And at the psychiatric level, again, ASD is the most common comorbidity and followed by ADHD. And regarding the intellectual level, yes, majority of these children, as I already mentioned, there is a bimodal distribution. So majority might have a normal IQ also, and severe to severe impairment is also possible. Then academic level, they have impairments in reading, writing, mathematics, and all. And neuropsychological level, they have difficulties in sustaining attention, cognitive inflexibility. So there is a clear cut demarcation between the clinical features which happens in children as well as in adults. So in children, as I already mentioned, it is higher overactivity, impulsivity, ASD, ADHD, less psychiatric comorbidities. So normal IQ is predominantly found, and the individuals, nearly 58% had difficulties in academic performance, but only 48% of these children were properly evaluated. So as it moved towards the adulthood, what happens is we have a lot of anxiety, depression, mood swings, obsession, and self-injurious behavior. Less of ASD, ADHD, as we all know. Diagnosing ASD, ADHD in adulthood is a real challenge, and we don't have a lot of standardized instruments or people who have been trained enough to diagnose the neurodevelopmental disorders in adults. So it is again a under-recognized phenomena. So based upon these things, what implications have been given in the TOSCO study? So in TOSCO study, they stated that even there are TSC2 mutation, then there are high neurodevelopmental disorders like ASD, ID. But when there are TSC1 mutation, then there is high internalizing disorder. For genotype alone was a poor individual level predictor. So despite of this much high burden, yet psychiatric diagnoses were infrequent and often delayed, because it might be because of the reason that majority of these children step up into pediatrician's office first. So the pediatricians has to be they need to be sensitized regarding referring these kids for the future TAND assessments. So findings strongly support annual structured TAND screening and multidisciplinary lifespan oriented care model, because I already mentioned that every need of the child is very, very different, and the needs tend to vary across the lifespan. So the child might have prominent academic difficulties when it is young, but when it grows, there can be a different behavioral needs of the child. So every year the assessment need to be repeated. So now coming to the last part of the presentation, the pharmacological option. So first is, like I already mentioned, very good seizure control. So most of these children, they tend to have multiple anti-epileptic drugs, as the drug resistant epilepsy is very, very common. Then surgical therapy, it is recommended only when there is single focus. For example, cortical tumor at one single site resulting in focal seizure. So vagal nerve stimulation is actually an invasive neuromodulation that is approved for drug resistant epilepsy, that can be tried, and seizure focus resection, tuberectomy, and targeted drug therapy, like the help of mTOR inhibitor, that I will be explaining later. As we all know, the hyperexcitability of the mTOR signaling pathway is resulting in tuberous sclerosis. So these days, drugs have been evolved to target the hyperexcitability of this thing. So sirolimus and everolimus are two drugs that has been tried in these children. So sirolimus has a multiple dosing like 0.04 milligram per kilogram, 0.03 milligram per kilogram based upon the weight, and everolimus is given as 3 to 4.5 milligram per meter square of the body surface area. So what animal studies have proved that it has improved the learning and social deficits in TSC modeled rats, But in human studies, only open label studies have showed some sort of improvement. But RCTs have failed to show any improvement in terms of neuropsychological functioning as well as autistic behavior. So, two RCTs in children has also stated no changes in the autistic behavior. So, what is the evidence for mTOR inhibitor? It is actually inconclusive in neurocognitive function. So, positive neurocognitive effects have been there, but we don't know whether it is because of the epilepsy control or whether the because of the control of the mTOR pathway. That is still a debatable portion. So, definitive evidence for use in epilepsy, both as an adjunct as well as monotherapy. So, before initiating these drugs, we have to do a baseline fasting lipid profile, liver function test, and HbA1c. Now, coming to rapamycin. So the mTOR pathway name is itself given because the rapamycin drug is able to block this pathway. Again, animal studies have proved some good evidence in bringing electrophysiological changes in the cerebellar Purkinje cells and all. So currently in humans, only phase 3 trials have been going on, and one RCT has showed some efficacy in autism. It needs a lot of research in this area. So, and rapamycin is a drug which can be used as an adjunct to the mTOR pathway inhibitors like everolimus also. So evidence from human studies is still very inconclusive. Now coming to psychosis and behavioral disturbances, yes, we can go with our regular antipsychotics. So with children with more than 6 years, FDA approved medications for ASD or risperidone and aripiprazole that can be tried in children. So for children more than 11 or 12 years, we can go for quetiapine, and in adults flufenacin has shown some evidence. So in case reports only there have been a significant reduction and it is very effective for challenging and repetitive behaviors in ASD. Again, we do not know whether it is actually helping for the tuberous sclerosis associated challenging behaviors or whether it is only addressing the ASD related challenging behavior. So that is again a questionable debate. So evidence is like the tolerability is good, and the adverse effects we all know that with the antipsychotics is very high, and controlled trials are still lacking. So whenever we initiate antipsychotics, we have to have in mind that the common problem in these children is epilepsy. So we have to choose medications which will not affect the seizure threshold like olanzapine, quetiapine, and aripiprazole. And mood stabilizers. We have been keeping on saying that there is lot of aggression and anger outburst in these children. So choosing a mood stabilizer becomes very important. So and as we all know that there can be renal damage from this tuberous sclerosis. So these children cannot tolerate lithium. So the option left is either valproic acid or second generation antipsychotics. Case reports have shown great evidence, but again, control trials are lacking. Now coming to the neurological aspect, that is the anti-seizure medication. So human studies, RCTs have proved that when the child is able to have a very good seizure control, then that itself improves the cognitive neurocognitive profile and social deficits. And we have also seen in practice that children who have very good seizure control, they are amenable to therapy, they are amenable to other pharmacological agents, and they show very good response to that. So, and animal studies also they have showed that there are some correlation between controlling the seizure as well as bringing the cognitive improvement in these children. So, in infantile spasm, as we all know that vigabatrin is a drug and it is available in sachet form. ACTGs is an injectable, and other options like tuberectomy, we already discussed that, vagal nerve stimulation, and yes, ketogenic diet has got very good evidence in case of pediatric drug resistant epilepsy. So coming to SSRIs indications, as I already mentioned that in adults there can be a lot of obsessions, anxiety disorders. So in that case we can choose SSRIs and we have to choose medications which will not alter the seizure threshold like venlafaxine. And one study has proved very good efficacy with escitalopram and bupropion. Stimulants, as I already mentioned, that ADHD is again a very common comorbidity. So we can choose stimulants, but again we have to have in mind the seizure, which is the commonest comorbidity. When a child has very good seizure control, no repeat episodes in past 3 to 6 months, then we can very well choose methylphenidate for co-occurring ADHD. But we have to start low and go slow, and we have to be frequently monitoring the child for any sudden onset of seizure exacerbation. And clonidine, guanfacine, there is not much evidence. Now coming to non-pharmacological management, as I already mentioned, it is a multidisciplinary team has to be sought in the treatment. So whenever you combine the pharmacological along with individualized educational plan, then along with behavioral therapy, then it has found good evidence in improving the pro-social behaviors, reduces the defiance in these children, and verbal and non-verbal communication also improves when we have a multidisciplinary care model. So again, pharmacological and non-pharmacological managements, when clubbed together, they have shown the maximum evidence in controlling the autism spectrum disorder symptoms, OCD, aggression, and low frustration tolerance. So this is one 12-year-old girl child who presented to our center with developmental delay, seizures from 4 years of age, and post seizures, the child had increased irritability, suspiciousness, and aggression. So we administered the TAND checklist. So in the TAND checklist, I was able to find that the child had behaviors in almost all domains, and the child had fulfilling the criteria for ASD, ADHD, and psychosis. So initially, the parents reported that all these behavioral disturbances happened only after the seizure. But over the period of time, by taking a longitudinal history, I was able to observe that the child had neurodevelopmental deficits from a very early period of life itself. And the IQ, we subjected her to IQ assessment, and the IQ was only 21 to 34, and the child had difficulties in schooling. These are the generalized discharges which was found in EEG. And in clinical course, I was able to find that the child got admitted for the seizure control. ASMs were initiated, and we were able to see hypomelanotic patches at the back, and EEG showed the generalized spike wave discharges. So initially, we suspected these behaviors as post-ictal. So I started her on risperidone, but the seizures got controlled. So as I already mentioned, when the seizures get controlled, there should be some improvement in behavior, and the child is already on risperidone. But the behaviors persisted, and there was no response with risperidone either. So I shifted to olanzapine, and over the longitudinal course, I found very good response with olanzapine. So that's it for today. So this is the end of my presentation. Kindly post your questions in the chat box. Thank you.